So let's talk a little bit about theory. Because as I mentioned a moment ago, we can use theory in an informative way when we're tailoring interventions to help us to explain and predict social phenomena. And so if we incorporate different theoretical perspectives for different conditions, we can then explain why a given presentation is occurring, why an individual is maybe acting the way that they're acting, or why a given intervention is effective in treating a specific condition. So optimally, you want to link your theory to the therapeutic interventions you're using. So if I was looking to decrease a problematic behavior that a child was exhibiting, and I was analyzing or I was explaining that child's behavioral difficulties from the perspective of behavior theory, that would suppose that the reason why that child's engaging in a particular behavior is because they're being reinforced for it. So the consequence is driving the behavior. And that's overly simplified, but I think that kind of captures the point. So the therapeutic interventions I would use would be behavioral in nature and would aim to decrease the consequence or the attention given that is increasing that given behavior. It's sort of like a child in class who says something to act like the class clown and all the kids laugh. That reinforces, and in behavior theory would increase the likelihood of that behavior happening again. So when we connect theory to practice, that helps us in a way come up with an organized way or an organized system of knowledge that helps us describe, explain, and again predict social phenomena. And do know that there are many theories out there, and not all social workers agree on which are the best theories. So when you are, and as you have been engaging in practice, really looking at what are the theoretical underpinnings behind the interventions that you're using. Now, when we talk about emerging practice models, I will describe some of the theories inherent as to why those particular interventions are purported to address a certain mental health condition. But there is a lot of uncertainty about how many of these models work or why. And so that's something to consider when you are looking at the evidence and deciding whether therapy X is the best choice to utilize for a client with a presenting problem. It's one piece of evidence that you would need to make an assessment as to whether that was the best practice for you to use. So other criticisms that we can effectively address is the evaluation of our practice in clinical work. So again, a concern being that we don't evaluate our practice, even though NASW in fact says that we have an ethical mandate to do so. But how do we evaluate our practice? And to that, we would respond that we use systematic measures to evaluate progress. And in a way that complements clinical judgment. So for example, if you have a client with anxiety, or even using Dr. Cooper's example, she tracked outcomes each week. And the way that she measured improvement was the number of ritualistic behaviors that were occurring. And that was based upon client self-report. Now, there are inherent weaknesses to self-report versus other methods of data collection, but that is a perfectly reasonable way to assess change over time. Using treatments with no evidence base. So for that, we'll talk a little bit about the COPES model as one approach, and it is one of many approaches in which we go about thoroughly assessing the evidence and behind a given intervention or lack thereof. And then finally, generalizability. And we'll talk more about generalizability in Module 3. But there are ways in which we can disseminate our methodology in terms of how do we put all of these pieces together with respect to the evidence, our clinical expertise and client preferences. We can actually do clinical research that's clinically informed. So at some point, this could become a study. If you test it on enough clients and you find a favorable outcome, you can standardize and manualize your approach. So there's many ways in which we can address generalizability. So COPES, the Client-Oriented Practice Evidence Search Process. What is it? It is one approach, by far not the only approach, as I've just mentioned, but one approach used in order to evaluate the rigor or the evidence base behind a given intervention. And it doesn't have to be intervention specific. It could be what kind of assessment or measure you would use, or basically anything involving clinical practice and decision rules about what is the best tool or best treatment or best techniques and so forth. There are weaknesses to this approach, as there are to all approaches. And so as we walk through this, keep in mind that this does have areas in which it may not be feasible, there may be problems with it, and part of your thinking as a critical thinker is to really thoroughly evaluate this approach and whether it would work for you as an evidence-based practitioner. If you look below, and we'll go through each one of these in detail, we move from the question the investigative question that we have originated all the way up to testing and reevaluating the evidence and potentially modifying future practice. So the first step is to develop a well-articulated research question. So Schlonsky and your other readings talk about how to develop a well-articulated question. And so reading Schlonsky's article, you know that there are some key components to it in terms of how you would formulate a question that includes the client type or the problem, what kind of therapeutic approach you are you're looking to evaluate or assess if you're assessing an intervention, alternative questions or alternative interventions that you would compare. So for example, what is the alternative? Would you want to compare individuals who were receiving equine-assisted therapy for anxiety with no service or with an alternative service? And as we move into the semester and we talk about the levels of evidence or the evidence behind some of the interventions that we'll be talking about, some studies have compared an emerging practice model to an established practice model. So, for example, for depression, it is not unusual that you might want to compare, say, equine-assisted therapy to cognitive behavioral therapy. So you have an emerging practice model that you are measuring against an established practice model. And that enhances the relevance and the rigor of that evidence towards equine-assisted therapy if you find that it's associated with therapeutic change. Okay? But back to the question, you would need to make a decision be it if you were studying interventions or you were trying to find an assessment tool, what the comparison is. What is X? Is it nothing? Is it another therapeutic intervention? Is it another instrument? And then what are you looking to accomplish? So if we're talking about anxiety, quite plausibly, you're looking to decrease symptoms of anxiety. You might also be looking for functional improvement. So that is something else you would want to specify in your question. So an example of a well-articulated question might be, if an African American female with social phobia receives equine-assisted therapy or eye movement desensitization and reprocessing, or EMDR, which approach will effectively reduce symptoms of trauma? So the second part of the COPES model is to conduct a literature search. And I'm sure you're well versed in how to conduct a literature search, so we're not going to go through it completely. Do know, though, that the type of search that you do is in some way dependent upon the access that you have to search engines and to journals that are available. So for example, each university, like NYU or Southern or Columbia, is connected to and purchases journals, a certain number of journals in different fields and different types. And while there may be similarities across institutions in the journals they subscribe to, they aren't exact. So if I went to NYU and I conducted a search through NYU's electronic library resource, and someone else went to Columbia and did a similar search, we might get somewhat different results because of our institutions. And that again has to do with what journals they have, what databases they have bought into, and so forth. So Holden calls that filtering tools. And what those are is that these electronic databases, they provide access to a selection of information. Okay? So they're gateways that hold content in a given area. So when you're conducting a literature search, you start with creating search terms, and how you obtain those search terms may vary. You may be well versed in a field of study where you are familiar with the common search terms or terminology. You also might be involved in a specific area where there are a few search terms that can capture most of the information you need. One of my areas of interest is in peer-delivered services, and I'm specifically interested in peers who are trained caregivers who have had a child with mental health needs, who provide support for other caregivers. And the way that the peers are described and their actual titles vary incredibly. You'd be surprised across studies and across different information. So for example, they've been called peer advocates, family peer advocates, parent advocates, lay persons, community health workers. There's a whole range, but there are differences between them. And some people use these terms interchangeably. It becomes difficult if you are running a search on peers and you use a certain phrase and not use another one. You're then missing out. So in your development of search terms, you would want to go through the literature, do a basic search, and really look at the keywords and the way that those individuals or condition or whatever it is you're looking at are described. And you can develop pretty complicated searches. The link at the bottom of the slide will take you to an example of writing down your individual search terms and separating those terms by either or and in different ways in which you can capture the literature. Okay. You can also set parameters. So when you are in an electronic database, and they vary across databases. So PsycInfo has one set of parameters, Ovid Medline has another, but you can search by year, you can search by age group, you can actually search by type of study in some of these engines. So if you, or databases, so if you wanted to look at individuals who received CBT and that the study design was a randomized controlled trial, you could do that when some of these databases. Now, it's critical that you save your searches always, and that you review. So when you run a search, you want to look through what are the first 10 or 20 citations that you've gotten. If you have gotten citations or titles and you read the abstracts and they seem to be concordant with the area that you're interested in or that you're studying, then you know your search terms are probably very good. I've run searches before where I have used terminology and it has just kicked up a lot of results, and very few of them were relevant to what it is we were interested in. In that case, you need to really look at your search terms and refine them, and do repeated searches in order to come up with the literature that you need in order to move forward. in the COPES process. The third part of the COPES process is to critically appraise the evidence. And there are different ways in which you can do so. And we'll talk about some of those ways. Those may include validity. So how close to the truth are the results of the study in question? Also, you might look at the impact, and we talk about effect sizes. And what effect sizes means is really the size of the effect of the intervention upon a given outcome. And there's small effects, medium effects, and large effects. Obviously, if you had an intervention that had a large effect upon a given outcome, then that would lend support more so than a small effect. Also, applicability. Maybe you're looking at appraising the evidence with respect to how useful it would be. And that would include, is it feasible to implement in your given setting? Is there a cost associated with it that is reasonable? Some of these interventions are quite costly, and they require a lot of training and supervision. Sometimes developers will fly, or they'll relocate for a period of time, a couple of weeks, or periodically at that setting, in which they will train and work with the staff as they're implementing the given intervention. That costs a lot of money, and that may not be something that many clinics have in excess of. So when you're thinking of applicability, also look at it in terms of feasibility. Another issue is the resources that you can allocate to a given implementation of a given intervention. Do you have the space for it? Do you have, for example, maybe you want to conduct groups. Is there space at your facility to actually conduct groups? Or maybe you want to hold groups or an intervention at a certain time of the day, but the clinic is typically closed. So all of these factors play a role in whether it's applicable to your clinical practice. So you can also get very complicated with this. And in your readings folder on the G drive, I have uploaded something called the Quality of Study Rating Form. And that is a very, very complicated way in which you would go through and assess the evidence of a given study. Other ways, so that's something for you to look at. It's not something we'll be using. But other ways have to do with the level of evidence. So the rigor of the study design, and usually what we're talking about is the methodological approach, as well as how that study was conducted. And we'll go through two of those so you get an idea of what are the different levels of evidence in terms of research design. As I mentioned before, when you're critically appraising the evidence, some developers will offer training. You can get certified in different therapeutic approaches. Some certifications take quite a while, so you may have to not only be trained and supervised, but you may have to work on a case to completion. And completion could be up to 18 months when you consider people may not come in every week for service, and that there may be other interruptions in delivery. The client could also drop out of treatment, and in that case, there are certain certification or interventions that you are not considered to be certified in until you have run a case to completion. So we'll talk about that a little more thoroughly in Module 3. But just know that there are a lot of factors that you can consider when assessing level, when you're critically appraising the evidence. The fourth step of COPES is to apply the evidence. And when you're applying the evidence, you're actively testing it out with individuals with whom you work. So if you've decided to implement equine assisted therapy, you would use that therapeutic approach with your clients, and maybe you would choose a handful of clients in which you would first test it out. Now, when you're doing that, you would want to be considerate of the client's values, preferences, circumstances, and so forth. Is this a therapeutic approach that they feel will be helpful to them? Is it potentially relevant? Or will it be perceived as relevant? So all of these factors come into play when you decide to implement a given intervention. Now, you can test the intervention's effect on a small scale and evaluate those results using a process that is referred to as the SMART process, or the SMART acronym. And what the SMART acronym stands for is that when you are choosing to test and evaluate a new approach, that you choose outcomes to assess that are specific, that are measurable, that you can actually assess, that are attainable, meaning it is possible for individual X to experience a remittance in depressive symptoms, that are realistic, as I just mentioned, and that are timely. So, as an example, if you're testing a new 12-week intervention, you might have a group of clients, maybe again 4 to 6 clients, where you would ask them to complete a measure such as a Beck anxiety inventory before each session. And you would look over time at their scores or how they rated their anxiety, and optimally you would see improvement or a trend towards improvement over time in those 6 individuals. Okay? So that is a specific outcome. We're looking for reduction in anxiety symptoms. It's measurable via an instrument. It's attainable because you have the client there and you can ask them just to complete that measure before the session. It's realistic and it's timely. So it's not so infeasible that you have to dedicate so many resources or go through a huge procedure in order to capture the data. And then the 5th step, the last one, is to reevaluate the evidence and modify future practice. If you found amongst those 6 individuals with anxiety that a given intervention was associated with some improvement, so individual scores on the Beck anxiety inventory got better and better as time went on, then you might expand the intervention across all of your clients who have anxiety. So you might pilot it amongst a bigger group and then evaluate those results. And then if everything looks favorable, you would potentially implement that as part of standard practice. So that's a way in which you've moved from identification of a potentially effective therapy to actively testing it and then spreading it or diffusing it across your practice, a clinic, or whatever context you're working within. Okay, so that concludes Module 2. Remember, you have 2 weeks in which to complete all of the readings and materials for this module. In Module 3, we'll get more steeped in levels of evidence and evaluating practice, and we'll talk about translational research a little bit. So we will discuss efficacy trials, effectiveness trials, as well as ways in which we disseminate and transport interventions. There's no assignment for this week or this period of 2 weeks, but starting in Module 3, you will begin your online posting, and I will describe that a little bit more in detail at the beginning of Module 3's lecture.